Hello, hello, everyone. We'll give everybody a minute to connect to their audio and get fully logged in. I see some smiling faces. Hey, everybody.
Good morning.
Is it more
Afternoon.
afternoon? Oh my goodness. I
It's been
almost
one
said
of
good
those days.
morning too. It has been one of those days. No worries at all.
Yeah, I just
Um,
got it to share, by the way.
Yay. Oh, awesome. We were having some technical difficulties,
Oh,
so we agree with you that it's one of those days. So appreciate
I,
everybody's patience today.
I don't
Um,
have a camera on this computer. I'm sorry.
Oh, that's okay. Yeah, we don't require your camera to be on. So if your camera's not working, no worries. We just want you to be able to see and hear us. So no requirement that you have your camera on. I will ask everybody to go ahead and mute yourself if you're not speaking to us, because we have about 40 people in here so far, but we had quite a few that registered today. So we want to make sure everybody's muted just so we're not picking up all your background noise. Y'all remember how that works on Zoom. Um, Let me admit a few people more who are waiting here in my waiting room. But yeah, I'm Jeanette Davenport. I'm one of the social workers with the Kidney Pancreas Transplant team. Nice to see everybody. Thanks for joining. I have here with me Joseph Yelvington. He is one of our fabulous physical therapists here at Mayo Clinic, and he has graciously agreed to join us today to give us a little presentation about rehabilitation for kidney transplant and pancreas transplant patients. So I am going to turn the floor over to him. And Joseph, I'll be kind of moderating the chat for you.
okay.
If you have questions as we go, you can feel free to put them in the chat, or you can save them till the end, and then we'll have some opportunity for questions and answers then as well. Okay. All right. I'll let
Sounds
Joe
good either
take it
way.
away.
Hi, everyone. Hi, I'm Joseph Yelvington. I'm one of the physical therapists here at Mayo Clinic on the transplant unit. And what you're seeing behind me is actually a real gym. This is our new 12 North gym. This is not a background. This is a real gym. And had just had a Zoom call from here, and patient walked in. It's like, whoops. But it's a nice background because we're really advancing what we're trying to do for our transplant patients. And this is the advanced stuff. This is the second gear stuff. It's funny. I was working with a fellow today down the hall, transplant patient. So I'm up moving around really well. And I walked through his room later, and they said, "You about ready to go home?" Says, "Yeah, I'm about ready to get into second gear." And I ran back in here and I changed this presentation along those lines: first gear, second gear, third gear. And I went and told him that too. Not that it was good. He said he's a writer, so he wants some royalties, but he's not going to get it. So anyway, that's how we're going to move along. The rehabilitation, liver and kidney transplant, kidney and pancreas transplant, excuse me. Training the best outcomes in the long term, and how can we make the short-term outcomes easier? We have a little concept we call prehabilitation, trying to get some of these things done before transplant. I understand some of you may be planning to get transplant, maybe listed, and some of you had it completed and are post-transplant. We're going to cover some of all of these things in the next 45 minutes or so. Okay, we're going to start with during your stay. Mobility is responsibility of all staff. You're going to get physical and occupational therapy for pancreas transplant, maybe with kidney. Sometimes it doesn't. That's why we have this presentation. So if you're a kidney transplant recipient after surgery, it won't be so much of a surprise what's going to be happening. I'm going to have to click on these instead of scroll. But again, here's the gear thing. This is the thing I just put in. Prehabilitation, first, second, and third gear. We don't really have an overdrive yet. But the prehabilitation, this is the engine idling. This is where folks are waiting or have been listed or waiting to get transplanted or sitting. That's what the prehabilitation is. I'll go into more detail on that. First gear is the hospitalization. That's when you're recovering, still have the lines, trying to get the mobility going, trying to control your pain, trying to learn the things that are going to keep you safe. Second gear is going home with the family. And the third gear is the getting back to that full activity. Work and the long-term goals: work, travel, hobbies, exercise, family, leisure, those things. That's the third gear. We're going to address each of these individually. Now, prehabilitation or prehab, we want to talk about these things before surgery. You can imagine waking up and having this old man in front of you telling you he's going to get you up and start moving you around. That's me. And we're going to teach you how to be safe, how to control your pain, and we're going to throw a lot at you that first day, and how overwhelming that is, how to do the deep breathing the right day, what your family's going to do.
Oh, go ahead.
And
Hello?
particularly, yep, I can hear you.
Hello?
Yep, you're on. You might want to mute. So it obviously, after that transplant surgery, um, you have probably wouldn't have slept real good that night. You've had a few things going on, pain control, and the bed's not real comfortable. So the learning, it doesn't make for easy learning. And so a lot of times it's easier to learn beforehand. That's what's great about what we're doing here. And the fact of recording it for future use, we're going to get a lot of education done in a very short time that would normally take place the day after surgery. So the goal of this prehabilitation, is to get you ready for the surgery. So there's not so much of a surprise. There's a lot of fear going into it. And that fear can make things a little harder to bear. That's what we're going to try and manage here. Is how many things we're going to do to try and make that easier on you. So we're trying to get you ready for surgery, and of course, get you ready to go home, which is everybody's goal. A lot of times, liver transplants are a little bit different from pancreas and kidney. Liver transplants, they've got a lot of problems with encephalopathy, and the lab's getting off on peritonitis and ascites, and they have to come in a lot. And so they get this education before surgery, not so much with the kidney and pancreas population. So this is the way we're going to start doing this from here on out, thankfully. And thank you for the invitation, by the way, Jeanette. And I scroll down just a bit. Now, there are 3 basic prehab topics that I'd like to talk about. These are the things that, as I'm sitting on the side of the bed, I'm saying, man, I wish we could have talked about this beforehand. So we're going to talk about it beforehand. There's 3 things I'd like people to try and do to get ready for surgery, for abdominal surgery. 1, get good at belly breathing. I'm going to go through this several times during this discussion. But the belly breathing is important. Get really good at that before surgery. You can understand why that would be easy. 2, get really good at walking, because walking is always going to get you out of here. And there's some transfers that I like people to practice before you've been surgically altered. I'm going to go in these individually now. Now, diaphragmatic breathing helps with several things. It's really tough after surgery, but it's really important. And throughout my career, I've found all the things it does do. And it's not just a matter of filling the lungs to prevent atelectasis and the collapsing of the lungs, which happens very quickly. I bumped into a colleague, and I'm trying to go off on too many tangents, that said this happens after knee replacement surgery. Certain number of people, have had knee replacement surgery, which is a 45-minute surgery that doesn't involve the abdomen, start developing this collapsing of the lower lung fields. And so it needs you deep breathing. It's just really hard after surgery. So get really good at practicing that before surgery. Really good. I mean, not just, but really good before surgery. We do that with shoulder replacements. People are going to have that done. Is get in and get really good at that range before surgery. The diaphragmatic breathing also helps with abdominal muscle spasms. We're going to go into a lot of detail about how those muscles after surgery are going to try and protect themselves by tensing, and this is one way of controlling. It also relaxes the entire body. You're going to be going through a lot. The body's going to need to relax, and we'll work on that throughout your stay. And here's what I didn't realize. I was at a course the other year, and that the belly breathing assists with bowel movements. The belly breathing, it's not a lot of movement, but it's 28,000 times a day. And that 28,000 is partially responsible for the pressure of getting the bowels moving. And I didn't realize that. It was actually a pelvic floor discussion. But if you're not belly breathing because you're in pain, that could slow that down, which is one of the many reasons those bowels will slow down to some degree. Now, the belly breathing is pretty simple. I've got just a picture of this fellow here pushing the stomach out. That's belly breathing. It's isolated belly breathing. But this right here is where the scar is, and so it's going to be tough to do. And if there's not, sometimes the scar is over on this side, and it can be substantial. But that's why it's so hard, because you're trying to expand an area after surgery that just got surgicalized. It's going to be hard to contract that. So that's why I want you to practice a lot before surgery. And I mean to practice it a lot. I want to mention one thing, though. This little gizmo here, the spirometer, that little thing that you attach this tube to, and you suck on the tube and make these little balls go up. Real important to train you how to take the deep breath, but you're already going to be trained beforehand. A lot of people treat these balls like golf balls, and they try and knock the heck out of it. And so they'll be deep breathing, and they'll just go. "Ugh." You don't have to go that hard. So I like to call. Even I heard one of the lung transplant patients say, you know what, this is starting to hurt people so bad. Maybe we should just find another way. And that's when I come to this yoga breathing. The other functions of that diaphragm are to relax. And if you're breathing really strainful with all these lines in you, it's going to be uncomfortable. So sometimes it's just a matter of just a slow, deep, relaxing breath. And take what it gives you. This is what I tell everybody. Don't force it. Don't, but just take what it gives you. You'll feel tightness. That's okay. But I don't want a lingering pain after this little simple exercise that should be causing you to, this should be promoting relaxation. So practice this beforehand because you'll be starting this as soon as you get out of surgery, is trying to get that the lungs filling up because you don't want to develop a cough. You want to get this started early because you don't want to be developing a cough. And it'll help with relaxation as well. Matter of fact, since the guy talked to me about the gears, I went back and talked to him, and I've never seen anybody inflate his belly like this guy just did after all these years. He's a musician. He's used to taking massive deep breaths, and he's moving almost too easily because he's gotten so much mobility now. He's moving too easily. I just went and had that discussion with him after we had to compliment him on the gear mechanism, the gear concept, and he really impressed me. Okay, so the belly breathing is going to be the first thing. The second, the most difficult part of mobility is getting up and down after surgery. There's a couple of ways which you have to get up and move. And I'd like to practice these before surgery where it's not so difficult. One of them is the log roll. You're going to have a big scar here. And this is a concept that was taught to us by neurosurgeons. When they go in, they do back surgery. They think, don't you tear those bolts out that we put in your back. And so they do a log roll where you roll to the side from this position and push up with your arms or in the bed rail to attain sitting. I encourage you to practice this. Roll all the way to the side and drop the legs and sit up and practice that over and over again. One thing I can't tell you is which side of the bed is easier after all this time. Some people say it's the left after kidney surgery. Some people say it's the right. Do you lay on the sore side or do you lay on the good side and use the sore side to get up? So this is one of those two things that I just want you to practice, make it all easy. This is a 2-second maneuver. It's and so we can minimize the amount of pain with that first maneuver. Okay, so the other one is this one. Is practice getting up and down without holding your breath. You'll practice doing this without holding your breath. You practice this one, just the getting up and down out of a chair without holding your breath. Just practice these two. We're going to show you some shortcuts to this. Some people who are taller, I like to put blankets in the chair so it's just not so much of a strain. But you can see when you go to get up, this may be hard to bend those hips that way. And so people don't. And so they don't quite go as far forward, and it's just harder for them because the legs aren't strong enough to get them up. And so I really like people to work on that side lying exercise, bringing the legs up to 90 degrees, rolling to your side, dropping them off, and sitting up and practicing that back and forth, because you have to get back into bed. And then practice some squats to get you good and strong here. And of course, try not to hold your breath. This is the hardest part. If we can minimize this, we can really take a lot of the discomfort out of those first days of mobility. So it's the transitions, it's the deep breathing, and walking. Get yourself as a good walking shape as you can because that's what's going to get you out of here. We walk not to get you in shape while you're in the hospital. We're going to do it a lot. Not as much as we'd like, but we're going to do it plenty. And again, we're going to make that as easy as we can. But walking as get you out of here is going to prevent those complications. So if you can get out and walk as much as you can beforehand, 2-3 times a day, and if you have to, if you're kind of weak, use an assisted device. Use an assisted device to make sure you keep safe, just to keep as much time on your feet as you can. All right, so it's the walking, deep breathing, and those transitions. Now, I want to talk to you about pain. That's the before. Pain is more than you might think, and I've over the years of dealing with it, I've kind of defined it as pain. Yes, you've got surgery. There's going to be pain from the surgical site, but some of it we can manage a little bit better. And I like to do this pain education beforehand because it's going to make things a little bit simpler and honestly easier afterwards. I still remember in high school looking at an old movie of perhaps it was in college, of someone who did a study. And if they told you that there was going to be a lot of pain after the certain procedure, you were going to need more pain medications, as opposed to somebody who said it's not going to be that much pain, or we're going to talk about how to manage that pain. They didn't need as much pain medicine. Now, that study was probably in the 70s or early 80s, but still, there are in fact ways of controlling this pain. You've heard of a placebo effect? This is called the nocebo effect. If you tell somebody's going to hurt, it's going to hurt, they're going to expect it to hurt. But these are all the ways we're going to try and manage that. To manage the level of pain and how long you're going to hurt. And if you get sore, we're going to get you in the chair and show you how to control it. I spend a good portion, I can't say a majority of the session, but a good portion of the session trying to do just this and trying to get the nurses to do the same thing. Because if we can get your pain down, you can mobilize fine. If we can manage the lines for you. So I really emphasize this. So pain comes from 3 different areas. There's surgical, obviously. There's the muscles around it. And then there's this little strange guy. Even when there doesn't seem to be involved, those bowels seem to sure want to make themselves known. It becomes a real issue. And I'll tell you a personal story about how horrible that is. Now, the pain from the surgical pain is the stuff you expect. You got a scar there, the pain's going to be around that scar. And you get your medications every 6 or 8 hours, and you have a button in between. And if you miss those, you'll notice a couple hours later that the pain starts to increase. This is what defines the surgical pain. The pain's right around where the surgery is. It's going to be right around that area, and it develops over hours. You make sure you get your medications on scheduled, and then you have a patient-controlled anesthesia button that they will give you to use in between. Now, it's simple, but there's another one. It's the muscular pain. Now, the muscular pain starts near the surgical site, but it starts spreading out. Where the surgery site is, you have all these layers of muscles. You have the rectus abdominis, you've got the transversus, and you got the obliques. And you're going to feel that pain start spreading out. And that's as those muscles are tensing to try and protect that area. That's pain that will develop over minutes. You'll be in a certain position. You realize you're starting to get really uncomfortable. That's not that surgical pain so much that develops over several minutes, but over a short, very few number of minutes. And it can occur when moving, when tensing, and when we mentioned those transitions. You go to get up, oh, you're going to feel that. But there's ways of controlling that muscular pain. Lots of ways of controlling the muscular pain. The first one, and this is probably the first thing you do when you get up that first morning, is if you're in bed. I did not do that right, excuse me. Sorry, I don't know why I kicked over that far. The first one is to reposition. So if you're in a position that you get sore, we all do this. We micro adjust. But in the bed, and I actually was going to put a picture of these beds, it's hard to micro adjust. When you're in that bed, there's kind of a pit that develops. You've been in for several hours, and it's hard to get out of it. The surface of those beds are very slick to keep you from tearing your skin. And so you slide into the bottom of this bed, and you get stuck there, and it's hard to move out of it. The problem is as you're in that bed, you slide and you curl up around that scar. And so very quickly that pain's going to get uncomfortable and you start using the PCA. When that occurs, and it's times when I walk into the room the first time, the first thing I do before I even ask your name is I'll get nursing to slide you up in the bed so that we're taking you out of this position into this position, into what we call the beach chair position, because where that scar is, we don't want it crunching. We want it open this way. So that's what I teach the nurses to do as well. As that pain is starting to come up pretty quickly, adjust them at bed, then get the medication, because it just takes a couple of seconds. Once we get you into the recliner, as opposed to the bed, it's got armrests, so you can undo those little micro adjustments that we do all day. That's going to make things a lot easier. We mentioned it before. Another way of controlling that muscular pain is to not bear down. Try and blow your air out as you move. Avoid the breath holding. Here's an important one. When we walk that first time, we're going to use this podium device, this thing here. It's like a brace that's not quite around the body. We're not going to make you pick up a walker and move it and pick up a walker and move it. That would be uncomfortable. So we're going to use a podium that you can kind of bend on and lean on and take the pressure off your stomach. And that kind of goes into this next point. If you've had surgery and you've been in bed all night, it's not going to be so easy to just stand up straight. I drive home 20 minutes. I can't stand up straight after driving 20 minutes. It takes me a minute. So people are going to tell you stand up straight, and you're going to say, just give me a minute, I'm straightening up. But this little device here, you can put all your weight on your arms and just relax. And it takes a lot of that muscular pain away immediately. Some folks will walk on that two-wheel walker, and when you put them on this one, they can go twice as far because it's just easier, and it's just easier because of the pain. So this is just a really good pain control device, almost like a pain pill, because it just takes pressure off when you're mobilizing. And we'll use this. I like to use this a lot. I like to use this until you're like doing laps around the unit. Then I'll put you onto the smaller walker. So again, we'll use the podium to take pain, that muscular pain away. The deep breathing, when all those muscles tighten and tighten, the belly breathing is what gets them to relax. If my shoulders get tight, I have to contract the other muscles and to relax them, just to get those to shorten and to lengthen and quit. And that's how you get those to relax. And the belly breathing is how you get all those abdominal muscles to relax. It's one of the first things you do, start noticing pain, is try a couple of belly breaths, just nice and easy. Nice and easy. The first one's going to be hard, second a little easier, third a little easier. But again, it should be, you might feel a little tightness, but I don't want to increase your pain, just like the deep breathing and everything else. Excuse me. Here's another one. I'm not sure what to call it. They'll give you a kidney pillow or a pancreas pillow that you can hold on to. Excuse me. Because, as I mentioned with the deep breathing, those lungs are going to try and fill up very quickly, and we need your deep breathing. But as you go to move, there's going to be a cough, and it'll be a hard cough, and we need a hard cough. Unfortunately, that stomach's going to kick out when you cough, and so you have to control that by grabbing one of the pillows. They'll give you a big, soft, cushy one, and you hold that against your stomach to allow you to cough. That's a good pillow for helping you move sometimes, too. Had one patient tell me, but I haven't tried this. I'm starting to recommend it. So he said you take that organ pillow and you hold it over your surgery site and you hold it for about 30 seconds and then cough. He said that made it so much easier to do. So the coughing, the getting up, the walking, we have ways of each aspect of your mobility making that a little bit easier. Because you're laying in bed and you haven't eaten and you hadn't slept, we call it putting wood on the fire. All these things just make for a big roaring fire of misery. And so by using a podium, by deep breathing, by using the recliner instead of the wheelchair, instead of the bed, we're going to start taking wood off that fire. So it's going to be a much easier fire to manage by using all of these techniques. Excuse me one last time. Now, many years ago, had a stomach ache, got bad. They took me to the hospital, local hospital, couldn't find anything. Sent me home. Turns out it was my appendix rupturing, and I had to go back. And by then it was bad. So I spent a couple of weeks in the hospital, and I just didn't realize they couldn't give me anything for pain because I had found out that I had a reaction to it, and they had to put me in ICU. So they couldn't give me anything but Tylenol. They even had to come in and open me back up in the bed because of the infection, blah, blah, blah. And despite all that, the most intense pain was this bowel pain, which is the strangest thing. I didn't know how to explain it. Nobody could explain it to me in 1979. But for some reason, the surgical pain takes a couple, slowly builds up over an hour. The muscular pain over minutes. But this thing, you'll just be sitting there, standing, walking, laying down, and all of a sudden you get this intense gut pain. And it's just intense. And everybody says it's the most intense pain yet. That's the bowels trying to do their thing. They're just trying to propel something. The good news about that pain is it goes away in about 30 seconds. Mine lasted for a long time over the years. It took a while to go away because it was such a complicated thing. But the bowel pain's pretty quick. It just goes away. If you just give it a second and not tense, that pain will go away. And that's when you shouldn't freak out about it. There's nothing going wrong. It's just what we expect. And we need those bowels moving. We actually kind of need that to occur. I went through husband coach childbirth training with my wife, and they described it very similarly. The bowel, when you're going through contractions, the uterus is trying to push the baby, and you don't fight that. You need to let that happen. Just like the bowels, you kind of need to let that happen. And then there's one more little thing that we'll deal with, and that's nausea. It'll sneak up on you. It's tough. And what I've noticed is, well, everybody has a pain tolerance. Some people have a good pain tolerance. Some people have a bad pain tolerance. Nobody has a nausea tolerance. You get nauseated, you're going down for a while, and this is tough. But there's means of controlling it as well, including the belly breathing. It seems like nausea, the gut can't figure out whether it wants to go send those contents of the gut up or whether it wants to go down. And so the belly breathing is one of the ways of helping them resolve that, as hard as that is. We also have these little devices called the Queasies. It's a peppermint that helps. It's an aromatherapy to try and help that nausea. Some people it helps more than others. And again, if there's nausea and you start getting cold sweat, this is one of the best things I've ever done, is get a cold cloth, ice cold if you can get it, and put it on the face, the neck, the back of the neck, and the forehead, and the chest. You cover this, and then in the upper neck, and it will do wonders of trying to control that nausea, because the nausea is hard. The nausea is harder to deal with than pain. It really is. But one other thing, and this is the first ask. If you're up and you start getting nauseated, please let us know. This could also mean your blood pressure is dropping. That's one of the big ask is let us know when something you don't feel right when we're mobilizing, because this could mean your blood pressure is dropping. And don't be. We've had a real plague of people who have no idea how to complain. We need like an instruction video. It's like, I didn't want to bother you. It's like, yeah, this is important. We need to know these things. Dizziness, lightheadedness. I had one fella, God, I guess it'd been 2 years ago. Tell me how you feel. Tell me how you feel. I'm fine. Says, I get him back to his bed. He says, you feeling better? He says, yeah, my vision's coming back. That's something you should tell people. That's something you should tell those kind of things. It's not complaining. We need to know them. So during your admission, you will be seen by physical and occupational therapy. Physical therapy and occupational therapy with pancreas transplant at the day after surgery. We'll do the best we can. Possibly have nursing, possibly have PT. Sometimes nursing will get in there before we can. And that's another reason I'm glad we're doing this, because this will show you some of the things to do if nursing wants to help you. It's like, hey, could you elevate that chair a little bit? I'm kind of tall. It may be tough. Hey, could I practice this mostly to the left side? Can I go to the left side of the bed? Those kind of things. And this is where one of these family can assist as well. You're going to have drains and catheters, IVs, lines in the necks. And that first time you get up, the getting up process is not that long, but it takes us a long time to get things ready. So bear with us to get everything aligned so that you're safe. And again, real important, as you go to get up that first time, this is not so much an issue with spinal surgery or knee surgery or orthopedic surgery. But after abdominal surgery, you'll feel the body just reacts strangely. So if you don't feel right, please say something. It's like, ooh, let me sit here for just a second. I'm being a little woozy. You would expect it. Some people just get vagal that way. Mobility. Here's a big one. We're going to ask you to walk many times a day. It's going to be tough for that very reason, because it takes so long to get the lines ready and the drains ready and the gown changed and those kind of things. But let's remember, walking is not the only form of mobility. It's also sitting, because when you go home, you need to be able to walk someplace and sit down. You need to be able to stand when you get there. So standing and walking are also good. And sometimes I ask family to do that. If walking is difficult, but you're getting up okay, let's just practice some standing. I walked in on a patient yesterday. He was so good to see. He's getting ready to get out of here. They're going home with family. Yes, you can stand up and just practice marching. We'll get the walker and have you walk later together. And also with ADLs, activities of daily living, being able to dress, get to the bathroom, take care of that, brush your teeth. Once you get there home, can you participate in these things? Meal preparation, all those. It's all of these things. And OT will work on a lot of these as well. get you to the bathroom and make sure you can do those basic care, self-care things. They call it self-care. Brushing the teeth, the hair, washing the face, those things. All of that is mobility. But it's hard to get, I think I addressed this shortly. Occupational therapy. What should we want to make? We've got several occupational therapists. We want to make sure we emphasize no bending or twisting, because you don't want to take that surgical site and do this. It's a healing process. We're going to get more to in third gear. We don't want to try and twist that out. We want to allow it to heal. And that not just resting of the body, but resting of that area. And how that's where you do it is not bending, lifting, or twisting. We'll get in more detail shortly. When you're dressing, bending forward is not what we want. You're going to pick the foot up to put your shoes on or to try and start your pants. Excuse me. We also have equipment, these adaptive tools she's talking about here to help you do that. Long handle shoe horns, sock donners, reachers, those kinds of things to try and keep you from having to bend forward. Because you start doing those things, and as you start feeling better, not only is it bad for the surgery site, but it's all we're going through to try and control your pain. That pain just might increase if you do the wrong thing. So these things, no bending or twisting, it's not just to keep it safe and protect that surgical site and everything inside, it's also going to make it more comfortable. Dress clothing and footwear that has ties and buckles or anything that's difficult to manage. Slip-on shoes, those new Skechers are wonderful, not that I'm endorsing them, will make your life easier. No flip-flops. Please, no flip-flops. We just don't want you, not just falling during after surgery, we don't want you stumbling, because then your caregiver is going to grab hold of you. And we just don't want any of that. Now, sleep. Bodybuilders don't build muscle in a gym. They break it down in a gym. They spend 2 or 3 hours a day breaking down in a gym. They spend the other 21 days putting that muscle back on with rest and with sleep. Sleep is going to be difficult to come by. I promise you. It will be, but we're going to try and do the best we can. One of the things I do, and I interview this early on, is at home. How do you sleep? Are you a side sleeper? Do you have an adjustable bed, flat bed? Do you sleep on a couch, a recliner? Because we want to try and do that here. Not a single individual ever has been able to tell me how much sleep a sick person needs. We know an adult needs 6 to 8 hours, but how much does a sick person need? 12, 14, 16? We don't know. They're getting about 3. I just looked at data yesterday of a sleep study we just completed. And there's a lot of things we're going to find out about it. But the first thing I looked at, most people are getting about 3 hours of sleep a night. I wouldn't show up to work if I was only getting 3 hours of sleep a night. It's very tough. So we're going to try and do the best we can. And part of that is trying to find out how your preferred sleeping methods are at home. If you're a side sleeper, you can't really sleep on your side. I'd go crazy if I couldn't sleep on my side. But we can manage a partial side. So instead of laying on your back or all the way on your side, we can get halfway here with pillows under your knees, pillows under your arms, and wedges. We have these wedges we can put behind your back to allow you to just rest. Now, sleep is going to become hard to come by, but that's where the family can come in as an advocate for sleep. Hey, he likes the noise on, he likes the lights out. He doesn't get up till 11 in the morning anyway, or she doesn't get up till 11 in the morning anyway, or anything like that. Let's try and mimic that. So try and get your best rest. So if we can't get sleep, rest. Rest as best you can. I'll describe that in a minute. Again, some of the details what a family can help with this resting part and the sleep part is environmental modifications. Control the lights, the noise, adjust them if you need to in the chair. We have earplugs available and eye blinders if we need to. And again, assisting staff with mobility. Sometimes I'll ask folks, do you need a pain pill or do you just need to get out of that bed? And they say, I just need to get out of this bed. The bed is so uncomfortable. That's where a family can assist. If the nurses know they have somebody close by to hold the chair, something like that, it's helpful. It's very helpful. Oh, excuse. My old physical therapy tech, Phil. He doesn't know I'm about to put him on one of the most important studies we've done in a long time. He helped me with this. He's now a physical therapist, but I found these old pictures of when we talked about this many years ago, the beach chair position. This is going to take pressure off the neck where you have lines. It's going to take pressure off your chest, so the weight of your shoulders aren't bearing down on your chest. You're going to find the nice angle in this chair that's just right. When you're in this beach chair position, there's a very specific angle that it's a sweet spot. It's a couple of 2 or 3 degrees that you get into that your family can help you with, and you can tell you get there because they'll do this. And I was describing this to a patient earlier. You get in that position and you go, you can finally take that deep breath. But it's multi-points of control. We want your neck supported, shoulders supported, hips supported, all those things. So just to allow that rest. You can't get rest until you're comfortable. But again, the family's got a huge importance in this thing because you're going to be going home with them. You can assist in the chair repositioning, those micro adjustments, aiding with mobility, aid with spirometry. That spirometer, that device, is going to wind up on the other side of the room, and they'll need it handy so they can do it, or at least be reminded to do the yoga breathing. That's so important. And honestly, my preferred way is the yoga breathing. And the other thing you can do, family, is make sure that they're not trying to knock the heck out of it. I got 1,100 yesterday. I've got to get 1,200 a day. And they're back in pain again. Now, after discharge, because what we're going to do here with family is we slowly graduate. We're going to walk with the podium, then the smaller walker. And as you start to get easier and easier with that, we're going to turn over to the staff, and then, of course, the family. And both the family and the patient have to be comfortable with that mobility. You're going to be working at home together. Let's make sure you're comfortable here before you head home. Now, gear 2 is that when you're at home and you're starting to normalize your activities of daily living and your mobility. Not forget, this is a healing process. You will not bend, lift, or twist after your kidney or pancreas transplant for 8 weeks. Don't test it. You're going to be feeling pretty good. A lot of people gets to them. They haven't been able to do a lot, so they're going to start testing it. Had this conversation yesterday. No, had the conversation, yes, yesterday. So he's going to start testing himself. I can tell he's the kind of guy who's going to start testing it. And sure enough, he was testing it the next day. Just this type of thing. It's being so eager to get back into your life that you're going 4, 5, 6 weeks, winding up in the yard, trying to do some more laundry. So let's be cautious of those things. And that's helpful for family members to watch those things. Again, rest and nutrition. Intake is important. Intake is important. We work with a respiratory therapist and social work and everybody else, and the nutritionists tell me, I ask them, what can I do for you? They say one thing, just let my people eat. They need their intake. It's so hard because the food's not hot and it's over there. It's not what they want. Let them eat. So we try and get that intake as best we can. Continue that at home. Pay real attention to that because that's what the substrate that's going to let those tissues heal while you're not damaging it. Walking is still the best activity. Progressive walking to prevent complications. We might send you home on a walker, and you'll continue with that until you don't feel like you need it. I haven't had to tell anybody to come off of a walker. As you start progressing that to 5, 10, 15, 20 minutes a day. Continue the deep breathing to help with that tissue mobility to make sure we're not minimize the scar tissue. And then you can slowly progress the aerobic activity, walking, level surface walking. Bike riding is okay as long as we don't fall. And this is for kidney transplants. Pancreas transplants are different. We have to qualify that. It's actually the last slide, but I'll mention it. Pancreas transplants. You're going to be on blood thinners. Can't have any impact. We don't want you falling or bumping or stumbling, anything like that. We also can't have you running into potentially falling off of a bike or anything impact like playing pickleball or anything for several months until you're off the anticoagulants. Yeah, no lifting for up to 10 pounds. After that, you can start slowly and don't pick up where you left off. I'm going to go into some more detail of that here. As you want to start getting into third gear, as you want to start getting into these things like golf and pickleball and hiking and car mechanics and things like that, it's not just your core that got weak. Because you haven't been able to do all the things you normally used to do, your hips are going to be weak, your quads are going to be weak, your ankles are going to be stiff, your shoulders are going to be stiff. So they don't want any core exercises for 12 weeks. But I've got a booklet we have that talks about some of these things. Is how to start strengthening in third gear. Now, here we're kind of going in a no man's land. It's easy to find lots of recommendations and lots of practice of what to do with gear 1 and gear 2. And of course, we know what the idling gear is. Here, it's a little bit different. We can't find a whole lot of information on this. So some of this is just recommendations. I tend to be someone who likes, sure, we're physical therapists and want performance, but I really want healing and safety. These things will herniate. You will get bleeds. So I want to make sure we minimize those. So as you go from the walking on level surfaces to start to hiking or stair climbing, you want to make sure that you're going slowly and maintaining maintaining you're not working too hard. That is too hard is you get out, you go for a hike, you come back, and you can't get to the bathroom because you're so tired. Things like that, or increased soreness around the surgical site. We want to be cautious of that. So it's strengthening of the hips, strengthening the shoulders and the arms, and then the core. And then we can start the sports again. If you want to look at getting to the golf game, because golf is a bit of twisting, unless you're really good with the hips. And if you do, start with a short effort. Start with a short game of golf, just chipping, putting to begin with. And if you need to start that long game, give it plenty of time. Plenty of time. Pickleball, people get pretty competitive with pickleball. I'm not sure how many people will plan on doing that, but again, with pancreas transplants, you're going to put this off until well after you're off those anticoagulants. That gives you more time to strengthen, though. That'll give you more time to strengthen the hips. That'll give you more time to strengthen your core and work on your balance. Those important things. I need to put that in here. Need to work on balance and control to protect that area. It's actually a very good point. But then slowly get back into it. If you're really into pickleball, because it's not just the sport, it's the social aspect of it, because that's the people you hang out with, start just with volleying back and forth. Please don't get competitive. If you think you're going to be the type that can't be not competitive, just put it off until later. And hiking. A lot of people want to go on hikes. Long-term goals are traveling and being with family. That hiking's really important. A lot to do, but make sure you pick simple routes first. They said the stair climbing is okay early on. Hiking's not much different from that. Just you got to watch your route. Make sure it's a simple route and it's a safe route, nice and wide, and you're not going to stumble. And then slowly start picking up the grandkids. Slowly start picking up the grandkids. That's the long-term goals. Travel and grandkids. If you have to pick up the grandkids, make sure that they're small or you squat down and have them crawl into your lap. Important things. There is, yeah, this is the thing about pancreas transplant, excuse me. I actually did that same mistake earlier when I spell checked it. Again, you'll be on blood thinners long after you will for kidney transplant. So you will be deferring all of these activities later, particularly ones that involve contact. Um, it could run the risk of stumbling, falling, or being hit by a ball. Bowling should be fine after the 8 weeks, but again, build up to that slowly. Build up to that slowly. Now we have this little booklet, Staying Active Before and After Transplant. It's got some great exercises that can be used through the entire stages, first, second, and third gear. They have sitting exercises for the people who are far too weak. We will sometimes initiate those right after surgery. The laying exercises for the people that are really debilitated. Those are people that usually are hospitalized already. Usually the liver transplants, things like that. The sitting exercises will give while you're in the hospital. And then they've got a series of standing exercises where you kick the legs sideways, backwards. The squatting exercises I showed you earlier are some of those. It's a good booklet to start progressing that into that second gear in preparation of the third gear. And we can actually create, before you leave, we can actually create your own personal exercise program after surgery. It's going to be pretty general because we can't monitor it. That's one of the things therapists have an issue with, is we can't monitor it. And some people get better this fast. Some people think they're getting better this fast and start pushing themselves a little bit too hard. So sometimes if we're going to give you that program, please stick to it and don't exceed it, because you can't speed up the healing. You can only slow it down. And if you're feeling good, and if you're somebody who's a laborer who's done things your whole life, feel like you need to get back to things too quickly, you can't speed that healing up. You can't make that healing any faster. You can only slow it down. Now you can enhance it with breathing, with obviously the nutrition and rest. But getting out there, moving it, and working harder isn't going to make it those first 4, 6, 8 weeks. We need to make sure that we rest it first. Because say, presently we are in the idling phase, the prehab phase. The things I talk about are the making sure you're practicing your deep breathing before surgery, getting walking as much as you can, and practice those transition movements without holding your breath. Then we talked about the pain control here. Really trying to emphasize that to take the fear out of it, to make the whole thing easier. So you need less medications. If we can teach you how to do those other means of controlling your pain, relaxing, deep breathing, adjusting, maybe a little less medication, those bowels won't seize up quite as much. You won't be as loopy. You make more sense. So that's the things we'll work on during that second gear. Third gear, we'll make sure you're safe at home with the family. We'll make sure you transition to that second gear well, but making sure your family is safe. One of our therapists said this funny statement. Sometimes it just comes down to the person who needs to catch you. So if they're, I can go home, I can go home. And Mrs. is saying, I don't think so. We want to make sure that all those questions are answered before we transition you home. And they rely on us greatly. They don't think about it. They rely on us. The nurse practitioners, the doctors, all the folks. Are you sure they're ready to go home? It's like, yeah. Let's make sure let's get some home health therapy to make sure they're safe going from that second gear to third gear, or make sure that there's somebody there 24/7, not just during the day, to help make sure they get from second gear to third gear. I really like that gear statement. He really helped organize things. He should be going home tomorrow anyway. Okay, so that's our gears. Do we have other questions we could open for?
Um, Thank you so much. That was awesome. Such great information. I love that gear analogy too.
I do
Very
too.
cool. So
Yeah.
timely it came up
I
today,
know.
huh?
It's morning at 8 o'clock, and I will be
That's
using it forever.
awesome.
Hmm.
Forever, right? Yeah. I did have a question that came to me in the chat where you had mentioned a couple of times just when you were speaking about like how the time it takes to kind of get somebody up and moving after surgery and all the logistics as far as what they've got going on. You had
Hmm.
mentioned some potentially like lines in the neck, and I had a
Hmm.
question about why would there be a line in the neck?
Just it's an introducer for this says in liver transplant, possibly in pancreas transplant. It's just something that's a little bit deeper line. That's a nursing question as to why exactly they have it, but there'll be lines here, here, and this will be here for the first couple of days. Yeah. And it's pretty, we stabilize it. We put a little thing on your head to make sure it's not moving around too much if you get it. I don't think the kidney transplants get that.
Yeah, I don't. When I've seen patients in the hospital, usually they do not. There might be some circumstances in which
Yeah.
there's complications that they might have one. So most of our kidney alone patients are probably not going to have that.
Hmm.
Kidney, pancreas, those are the ones I've seen it with. But it's always possible. But
Yeah.
so yeah, may not apply for you to you in
Right.
this situation. Looks
Hmm.
like we had another question in the chat, and just to let everybody know too, we do record these sessions, so if you are more comfortable putting a message in the chat or a question versus speaking, that's totally fine. But we did have a request for you to kind of demonstrate that breathing again, the breathing technique, the belly
I'm
breathing.
recording. Oh gosh. I hate making my stomach stick out. I spent 50 years trying to hold the sucker in. All these years I spent holding it in. Oh,
Right?
1 second. I'm glad I put on a clean t-shirt. All right. So this is the belly breathing. This is chest breathing. This is the belly breathing. Now, if you can do both together, that'd be impressive. But the deep breathing really involves 3 parts. It's the chest, the belly, and the spine. But you can understand why that's going to be difficult because you can have a scar here or here, and it's going to be hard to move that. But if anybody, and usually if you say deep breathing, most people immediately start deep breathing. But a lot of people deep breathe, they do this. They don't realize it's actually this. It's a lot more than we think. We rarely ever take a true deep breath. And usually if you see people do this, you know they're doing it because they do this. Their eyebrows come up. That's when they're working. That's
That's
when
how
they're
you know,
working
huh?
real hard. Yeah, because they do this. And that's why I want all of that tissue moving before surgery. I want all of that moving before surgery. And I think that's why that fella from the gear fella,
Mm-hmm.
the musician, was moving so well, if not too well, and without difficulties, because he was a musician and he could belly breathe just as good as I could there. He was able to expand all of that. So we didn't have to worry about that tightness after surgery. It's really important. One of the things I really wish a skill would people would do before they come in.
Awesome. I definitely think it helps too to do just like what you were doing to put your hand on your belly so that you can actually
Mhm.
feel your
Feel it.
belly rising and falling. I think
Very
sometimes for
good.
me it helps to lay on my back while I'm doing it. So
Yep.
you have it makes it a little easier to kind of feel that you're really getting the breath all the way deep down into your belly.
That's it.
But I'm
It's
sure there's some good videos about it too, like the breathing.
everywhere.
So if
Everywhere.
you
And even
YouTube
yeah,
it,
even on bed. It's funny. I walked into a patient's room. I do not watch this television show, but Drew was on, and she had another young lady, and they were talking about breath
mm,
work, and about just trying to keep the anxiety down by just breathing. That's what they were talking
hmm.
about on talk shows today at 2 o'clock.
Oh yes,
Yep.
it's kind of everywhere. So yeah,
It
if you were
is
to search, the yoga breathing or belly breathing, I'm sure you would find some good videos or illustrations that would
everywhere.
kind of talk
Yes.
you through it. Um, any other questions that anyone, if you would either like to unmute and ask it, that's okay, or if you want to put it in the chat.
There's
It looks like how many times a day should we practice the belly breathing?
3 times a day, 10 times. So do 10 times morning, noon, and afternoon, because that's what you'll be doing here.
Wonderful.
Yep.
All right. Okay, and then someone's asking about downloading the presentation, oh, the PowerPoint. So,
Hmm.
if you can always, if you can kind of, if you're comfortable with it, Joseph, you
I'm
can always,
fine with it. Oh gosh, that would be
okay,
so helpful. It would be
okay,
so
yeah.
helpful if they would do that.
So if anyone would like me to, I can email it to you. If you want to respond to the portal message invitation that I sent you to this meeting, respond to that and say, "Hey, I'd love the PowerPoint," and include your email address. Then I'll be happy to send that out to you later. Looks like I also had a question about just kind of how long to wait after surgery before certain activities like going on a cruise. Those are all going to be questions you'll direct to your doctor. Usually they're going to want
Sure.
to limit you a bit as far as your exposure to germs and all of
Yes.
that for the first like 6 months. So I'm going to venture to say it would be a definite no in the first 6 months, but after that, I'm going to defer to your doctor. I would ask your doctor that question. And then how do we get the book? Oh, the book that he's talking, the one that you're referring to on the last slide. I'm guessing that's
Hmm.
the book they're talking about. How do they get that?
That I will see if that we can get that uploaded available in the portal. We use hard copies, but it really is a good book to have. So I can find out if we can get that uploaded as a portal.
Awesome.
Yep.
Okay.
You'll see.
Yeah.
It really is a good book. I'm not even sure it was designed specifically for this, but it answers pretty much all the questions.
Mm-hmm.
Talks about posture and how to wrap your legs to control swelling, and it's a really complete book.
Oh,
Yeah.
nice.
Mhm.
Okay, I'm just
Okay.
trying to see if I missed any other questions that were in our chat. How long is the hospital stay? Now, remember, for a kidney transplant alone, your average length of stay is going to be 3 to 5 days. Of course, it could be longer if there were complications. For the
Hmm.
kidney pancreas combined, you may be looking at a bit of a longer stay, more of an average of 5 to 7. Again, they can always be longer if there are complications, but those are kind of the averages. Any other questions anybody has for Joseph? That was such great information. I really appreciate you coming, the
You're
whole
welcome
team, all of our patients, on
for
behalf
your
of
help.
everybody. We really,
I just
really want to thank you.
I appreciate this opportunity. I really do. It's really gonna
Yeah.
make our life make everything easier.
I love the whole idea of prehabilitation too.
Yeah,
That's
Bev. Yeah.
amazing. Like, I
Yeah.
love this concept. I'm going to be like starting to help you get the word out about that
All right.
for sure.
All right.
Okay, well, we will look forward to seeing everyone again next month where we'll have another topic. I believe our topic for next month uh, is perhaps going to be nutrition, but we'll kind of get a finalized
Good.
invite out to everyone. And it's the same day and time every month, so kind of keep an eye on your patient portal for those invitations if you'd like to join us again. All right. Thank you, everyone. Take care.
Thank you, ma'am. Thank you, sir.
Yeah,
All
you're welcome, sir.
righty.
Thanks.
Bye-bye.